Assalamu alaikum wa rahmatullahi ta'ala wa barakatuh. Good evening, everybody. My name is Dr. Tariq Alhat. I'm senior consultant endocrinologist, and I chair the webinar committee of the Arab Thyroid Association. It gives me great pleasure to welcome you tonight for the first copy of our thyroid educational series organized by the Arab Thyroid Association. I would like to thank our faculty for today, Professor Petros Peros from Newcastle, as well as Dr. Tania Jabir, who is consultant endocrinologist at Hamad Medical Corporation from Doha, Qatar. And the session will be moderated and chaired by my colleague and friend, Dr. Abbas Mansour from Iraq, who is also one of the board of directors of the Arab Thyroid Association. So with further ado, I will pass the center stage over to Dr. Abbas.
Thank you, Dr. Tariq. Thank you for introductions, for the all audience, the speakers. Please, just to remind you, when we start, we have a Q&A at the down. You can have a question for both speakers and write for whom you direct these questions. First speaker will be treating thyroid eye disease in either side of Atlantic, the cusp widen. Professor Petros Peros, he is a well-known, famous thyroidologist. He is honorary consultant endocrinologist at Royal Victoria Infirmary, Newcastle upon Town, UK. He is qualified from Newcastle University and trained in Newcastle, Glasgow, Edinburgh. He has served as a member of British Thyroid Association Steering Committee, Clinical Convener, Society for Endocrinology, British Thyroid Association Network, member of the Clinical Committee of the Society of Endocrinology, member of the editorial board of Clinical Endocrinology, and lead of the Society for the Endocrinology Department Peer Review, and the president of European Group on Graves Orbitopathy. Without further delay, Professor Petros Peros, for you have a 20 minutes or even extra 5 minutes, 25 minutes to present the thyroid eye disease.
Thank you very much, Dr. Mansour. I'll try to share my screen. And okay, so I'm having a little bit of difficulty. Oh, here we are. Okay. You can see, you can hear me okay?
Yes,
Yeah,
clear.
absolutely, yeah.
So thank you so much, Dr. Mansour. It's a huge pleasure and a real honor to be here. I'd like to thank you very much, and specifically and particularly Tariq Alhat for the invitation. And Tariq might remember this picture of the Edinburgh Royal Infirmary, and as he alluded, in our youth, we spent a bit of time there learning the dark arts of diabetes. So much of what I will say in the next 20 minutes relates to this consensus statement published by the European and American Thyroid Association, which I had something to do with. And it is freely available, full text on the websites of these two journals. But what I'd like to do is just very briefly go over some of the basics of thyroid eye disease, emphasize the importance of early diagnosis and treatment. I'll take you through how easy it is to assess patients in your endocrine clinics and referral criteria, and then a little bit about management. So, well, of course, it is a chronic disease, and it's closely associated with Graves' disease. We occasionally see it in association with hypothyroidism or with euthyroidism, and it's relatively rare, 1 in 1,000. And most importantly, it is associated with significant impairment of quality of life and socioeconomic costs. The clinical manifestations, the phenotype is quite variable. And just to give you a flavor, here is 2 extreme examples: the patient on the left with mild eye disease, and the one on the right who unfortunately has lost her sight. So besides severity, another aspect of the disease is activity. So that's the amount of acute inflammation that is present. And you can see an example on the left-hand side of somebody with active disease, where the redness and the swelling is obvious. And on the right is somebody who's gone into the inactive, burnt out phase. All the redness is gone, much of the swelling is gone, and she's left with just the chronic features. So most patients have symmetrical disease, but often it is not symmetrical, and occasionally can be purely unilateral, at least to the outside examination. In terms of cause, we're pretty certain that this is an autoimmune condition. And we know that because you can see lymphocytes infiltrating the target tissues, and TSH receptor antibodies actually are quite good markers for this condition. The pathogenesis is complicated. I'm not going to go through this, except to say that both humoral and cellular immune responses are involved, cytokines are involved, and the TSH receptor and IGF-1 receptor are involved. Now, the end result is that the target cell, which we think is the orbital fibroblast, is subjected to two things. One is it undergoes adipogenesis, and it produces excessive amounts of hyaluronic acid, which is a very hydrophilic molecule, and it draws water into the orbit, and that causes swelling. And the end result is essentially expansion of the retroorbital space. Now, I really do want to emphasize the importance of making an early diagnosis, because that means you have the opportunity for early treatment. And I'm rather embarrassed to admit this, but this figure of 31% of undiagnosed patients in a clinic comes from my own clinic, when on my registrars, Anna Mitchell decided to look at this. And we found that 31% had thyroid eye disease that had gone undetected. So our endocrine clinics, I would suggest, are reservoirs of undiagnosed thyroid eye disease. And our experience from our own clinic is that half of those that were undiagnosed actually went on to have various treatments. And the importance of this is that for many medical treatments for thyroid eye disease, there is this inverse relationship between potential for response and duration. So the further away you get from the onset of the diagnosis, the less likely the patient is to respond to treatment. And of course, to do that, you have to diagnose and you have to classify your patients. So I'm just going to spend a little bit of time showing you how easy it is. And if this is too basic, I do apologize, but I think it is rather important. So I would suggest that the next time you see a patient with Graves' disease in your clinic, and the diagnosis will be in the records and in the letters, the question that needs to be asked is, do they have thyroid eye disease? And if they don't, that's fine. If they do, then you need to work out how severe it is and how active it is, because that would guide you as to what you need to do next. So, as always, in medicine, we start with history taking, and these are the relevant questions that you can ask. Are the patients aware of any changes, recent changes in the appearance of their eyes? Do they have symptoms like gritty eyes, or excessive watering, or aversion to light? Do they have an ache or a pain behind their eyes, or when they move their eyes around? Are they experiencing double vision? And if so, is that just sometimes or all the time if they look in a certain direction, or is it constant? And do they have blurred vision? So if the answer is no to all of these questions, which the majority will be, and if the patient's eyes look normal, then they're extremely likely to have thyroid eye disease. So you can just relax and move on. However, if they do have some symptoms, or if their eyes don't look right, then you just need to spend a little more time homing in. And you need to find out from the history how long they've had the symptoms. Do you get a feel that the symptoms are progressive? Are they impacting on daily life? And then you need to do a quick examination. It takes no particular instruments or tools And the examination is focusing on the lids, on the conjunctiva. You look for exophthalmos and for restriction of eye movements. So you're looking for upper lid retraction. This is the normal position of the upper lid. And if you can see about 1 millimeter of sclera, then that's mild. If it is 2 or more, it's moderate. We'll look at the lids for swelling, both at the upper and the lower lid. And here's an example of mild lid swelling and one of moderate to severe. When it starts to overhang, that is moderate to severe. We'll look at redness of the lids, again, the upper and the lower, and we use the forehead for comparison. Here's an example of mild lid redness, one of moderate to severe. We look for conjunctival redness. So this is the scleral conjunctiva. And if you get involvement of about 1/3, that's mild. If it's more, that's moderate to severe. Conjunctival swelling or ecchymosis is rather rare. It's best seen right at the corner of the eye. And here's an example. You can see the conjunctiva folding over, and sometimes it is easier to see that from the side. Exophthalmos, if you can imagine a line going from the brow to the cheekbone, and if the eye is protruding beyond it, the patient has exophthalmos. I personally prefer to take a shortcut and take advantage of the fact there is a linear relationship between lower lid retraction and exophthalmos. So that's the normal position of the lower lid. If you can see about 1 millimeter of sclera, that's mild. If it is 2 or more, it's moderate to severe. These are some examples of restricted eye movements. The patient here has been asked to look upwards, and her inferior recti are so tight that she cannot elevate her eyes. This is a more severe example. The inferior recti are pulling the eyes down so much that this patient has to look, to tilt the head backwards in order to maintain binocular vision. And this is a patient with an obvious squint. The right medial and inferior rectus are pulling the eye downwards and inwards. This is the typical appearance. So if we're thinking about severity, then here are some examples of different severities. We call mild eye disease when it is not causing major problems with quality of life. And usually these patients have mild features, mild lid retraction, mild soft tissue swelling, mild exophthalmos, and no or intermittent double vision. And patients with moderate to severe disease, by definition, this is impacting on their quality of life significantly, and they have moderate to severe features. So you can see more exophthalmos, more lid retraction, more lid swelling, and motility problems. And then, this is the really severe end of the spectrum. You are very unlikely to see such patients walking into your endocrine clinic, but they occasionally occur. So this thyroid optic neuropathy in the left, a corneal ulcer developing the right eye in the middle, and the one on the right is really extremely rare when there is globed subluxation, and that is an ophthalmological emergency. And the other side of the assessment is the activity. And again, the history will give you a hint if there is a recent onset of symptoms, if the course is progressive, if they're experiencing pain, and if there are features of inflammation, the disease is likely to be active. And here are some examples. So redness and swelling, the hallmarks of inflammation. And these are examples of inactive disease. It's all burnt out. The eyes are white, much of the swelling is gone, and these patients are left with the chronic features. So if you're seeing patients with Graves' disease, then you really need to have links with ophthalmology, and you occasionally need to refer. And the indications for referral are pretty straightforward. Any patients with more than just mild disease deserves to be referred to ophthalmology. Also, if you're not sure of the diagnosis because it is unusual, if it is unilateral, for instance, or the only symptom is double vision, that is also an indication. And in the odd occasion, if you do come across somebody with sight-threatening thyroid eye disease, of course, that needs to be referred urgently. So I'm just coming on to the management now. And the first topic is simple measures. And right at the top of the list is quitting smoking, which is actually anything but simple to persuade people to give up smoking. However, it is important. The evidence is rather circumstantial and by association, but there is a strong association with current smoking and risk of thyroid eye disease. Patients who are smokers tend to respond less well to treatments, medical and surgical. But the good news is if they give up smoking, the benefits are felt fairly quickly within a few months. The risk goes down to baseline. Avoiding dysthyroidism is really important. This is our bread and butter as endocrinologists. And I'm sorry to say the experience certainly from the UK is that we don't do this well at all with our patients with Graves' disease. Following diagnosis, it is unfortunately very common for patients to swing from hyper to hypothyroidism, and this is not good for thyroid eye disease. Again, the evidence is circumstantial by association, but there's good clinical reasons why we should be very careful in maintaining thyroidism. So and especially post-radiation hypothyroidism does correlate rather strongly with thyroid eye disease. Avoiding radioactive iodine, this is one of the studies which was performed by our Italian colleagues, and there is an increased risk if you give radioactive iodine of the order of about 15%, and you can prevent this by giving a course of oral steroids. So other simple measures, artificial tears, they're very important. They provide relief from symptoms if they have surface symptoms, and they protect the cornea. One randomized controlled trial, a fairly large one, showed that selenium, a 6-month course of selenium in mild disease, helps settle down the disease quicker and probably prevents progression of the disease to more severe forms. So this is a mnemonic for the simple measures that one can take, and I use that just to remind me. So I've touched upon treatment of thyrotoxicosis, and radioactive iodine is best avoided. If you have to give it, then use steroid cover. We have experience, we've published it from observational studies, that actually if you wait until the thyroid eye disease is inactive, you can give radioactive iodine as long as you don't make the patients hypothyroid and you don't risk any exacerbation. There is some evidence that thyroidectomy is neutral with respect to the risk of thyroid eye disease progressing or appearing. But I would suggest, and this has been my practice for a long time, that if you have a patient with thyroid eye disease who has to have treatment for thyrotoxicosis, I think the best option is keep them on thyroid drugs as long as they tolerate them, and as long as that is achieving euthyroidism, there is nothing wrong for carrying on for 2, 3, 4, or 5 years. And indeed, our colleagues from Tehran have published extensively on their experience with long-term antithyroid drug treatment. So moderate to severe disease, well, I already told you about the American Thyroid Association, the European Thyroid Association consensus statement. A year earlier, the European Group of Graves' Ophthalmopathy published their update guidelines on thyroid eye disease. So I think we have plenty of guidance available to us. And to be honest, both of these are broadly very similar to each other, except there is a divergence of opinion in the recommendations for medical treatment of moderate to severe active disease. And I just want to spend a few more minutes on this. The European Group on Graves' Ophthalmopathy suggested and recommended intravenous steroids with mycophenolate as first line, and a variety of other options as second line. The American and European Thyroid Associations take a slightly different view. They divide the recommendations into preferred, acceptable, and may be considered based on the strength of evidence. And they also rather take the view that you've got to take into account the specific phenotype. And I think that is important. So you may see patients like this whose features are mainly inflammatory. So this patient has no proptosis, has no double vision, just a lot of swelling and redness. And there is plenty of evidence that in this case, intravenous steroids are the treatment of choice, and they will be successful in about 70 to 80%. And there are some other options if they fail or the patient cannot tolerate them. Then there are patients like this who have double vision, again, no proptosis and inflammatory features, and teprotumumab is helpful in reducing inflammation, reducing diplopia, and some other treatments may also help. And then you have this type of patient with proptosis who is also active and with moderate to severe thyroid disease. And in such patients, the evidence shows there's only one drug that helps, and that's teprotumumab. Now, if we look at the recommendation by the European group, this is based on two pieces of evidence. One is from this large randomized controlled trial comparing combination treatment with steroids alone. And this was essentially a negative study because the primary objectives were not met. But a post hoc analysis showed some response to the combination treatment. Now, if you're not familiar with the definition of a post hoc analysis, this is what Wikipedia has to say about it. The second piece of evidence that the European group has based the recommendation comes from a Chinese paper published in 2017, which is the most amazing result that I have ever seen of medical treatment. 90+% response, improvement in diplopia, mean reduction of proptosis 3.4 millimeters. That's better than an average surgical decompression and no reactivation. And I recall reading this back in 2017, and I thought that of it. So when I'm faced with kind of evidence and I need to evaluate it, I always think of a very dear friend and a mentor of mine, Mike Rawlins, who was the architect of the National Institute of Health and Clinical Excellence, and I had the pleasure of working with him as a colleague. And Mike Rawlins always, at every opportunity, will repeat his mantra that you need two independent randomized controlled trials pointing in the same direction to be confident that some treatment works. And so if we look back at the European group of Graves' orbitopathy, here are the two pieces of evidence, one from the Chinese group, one from the European group. Except the trouble is, just a few weeks ago, the Chinese paper was retracted because of irregularities with the data and suspicion of fraudulence. So is the combination treatment justified as first line, as suggested by the European group? Well, I will let you decide that. What about teprotumumab? Is that justified as a first line therapy? Well, it comes from two randomized controlled trials. These are the results. Good response, good reduction in proptosis, improved diplopia, downside, reactivation in about a third of patients. Having completed the treatment, the disease comes back. So yes, I think it is justified if you have access to it and if you can afford it. And at the moment, this drug is only licensed in the US, and 30 million Americans who have no insurance and the rest of the world cannot access it or cannot afford it. And just to give you an idea of how much it costs, this is a comparison to the various treatments in US dollars. These are American prices, European prices are usually half of that. So as cheap as chips, steroids $172. And as you go along, it becomes more expensive. And here's teprotumumab, $250,000 per patient per treatment. So this raises a number of ethical questions. Should pharma be allowed to do this? And what is our role in all this? And who should be making these decisions? And I'm always reminded of one of my heroes, Albert Einstein, who said this: only two things are infinitely, the universe and human stupidity. I'm not sure about the second. So I think we can add the greed of some pharmaceuticals to this list. And so in conclusion, we're in a strange situation. We have more choices than ever before, but there are also concerns because we have no studies showing whether treatments such as teprotumumab are cost effective. And I think the chasm between the America continent and Eurasia is widening. Thank you very much for your attention.
Thank you, Professor Petros. It was nice presentation. As you stick to the time. For the audience, please, if you have a question, write down on the Q&A and we'll have later on 15 minutes. Next speaker will be Dr. Tanya Jaber. She is a consultant endocrinologist at Hamad Medical Complex, assistant professor of clinical medicine at Weill Cornell Medicine, Doha, Qatar. Dr. Tanya obtained her medical degree from Weill Cornell Medical College in Qatar 2011. She went on to complete internal medicine residency in Cleveland Clinic Foundation in Ohio, followed by fellowship on endocrinology, diabetes, and metabolism at the University of Texas Health Science Center in Houston. She then passed a fellowship in oncology and endocrinology at the University of Texas MD Anderson Cancer Center in Houston, Texas. She is an American board certified internal medicine, endocrinology, and diabetes and metabolism. She is currently consultant in endocrinology at Hamad Medical Complex. Dr. Tanya will be talking about the pitfalls in thyroid eye disease in the region and beyond. Dr. Tanya is now for you. Please, for the audience, if any question, you can write it down in the Q&A. So later on, you have 15-minute Q&A. Thank you.
Thank you, Dr. Abbas, for the introduction, and I'd like to thank the Arab Thyroid Association for inviting me to their first webinar. I'm honored to be here alongside Dr. Petros, who is the expert in the field. So I will, I will not be going over the management of thyroid eye disease. I think for the most part, we follow the same evidence-based guidelines in terms of how we manage these diseases. But I wanted to shed light on, thyroid eye disease, maybe trans-Mediterranean. So Dr. Petros covered the transatlantic, and we'll cross back to our region here and kind of shed light on thyroid eye disease in our region, as well as maybe raise some pitfalls that Dr. Petros has already alluded to in his presentation, and maybe open it up for further discussion. Nothing to disclose. I just mentioned that. So, thyroid eye disease in the MENA region and the Middle East and North African region. And I think, I kind of agree along Dr. Petros' sentiments that, thyroid eye disease is undiagnosed. And I want to add that perhaps underreported as well, especially in our region. So the data for our region, is lacking. I had to really, kind of dig deep to try to find any data on thyroid eye disease in our region. And so the only thing available other than the Iranian data, which are more epidemiological, is this survey of clinical practice patterns in the management of Graves' disease in the Middle East and North Africa. So this basically is a survey that was sent out to over 350 physicians, both endocrinologists and internists specialized in thyroid management. And digging deep into this paper, there was one case where the respondents were asked about their management plans in a patient who had Graves' disease, who was a smoker with moderate and active eye disease, with a CAS score of 3. So 173 out of the 350 physicians who were surveyed responded. And when asked what their next step would be, around 2/3 opted to kind of refer to ophthalmology before doing much. And a quarter of them would order further imaging prior to seeking an ophthalmological opinion. And when looking on how the severity of Graves' orbitopathy affected our treatment choices, it was quite interesting. So this looked at the severity of Graves' disease, and patients who had risk factors for Graves ophthalmopathy, but no clinically apparent eye disease. So the risk factors include smokers and high TRAB levels, and their choices of therapy in terms of treating the hyperthyroidism, whether it's antithyroidal drugs, radioactive iodine alone, or radioactive iodine with steroids, whether low dose or high dose, and surgery. And the pattern is, perhaps expected, but I wanted to shed light on a few things. So physicians are more comfortable maybe recommending surgery at the get-go. So obviously radioactive iodine and surgery were recommended after controlling the overt hyperthyroidism, but as a definitive therapy for the hyperthyroidism. So more physicians opted for their patients to undergo surgery as the eye disease was more severe. And physicians who opted to treat the hyperthyroidism with radioactive iodine across all categories of severity of eye disease, and even in patients with no clinically apparent thyroid eye disease, but risk factors for the disease, when radioactive iodine was chosen, physicians tend to pre-treat with steroids rather than radioactive iodine alone across all cases. And while that, to me, that was both kind of surprising and not surprising. Not surprising because this is what the guidelines tell us. Steroids, for the most part, are recommended, for most patients who have either risk factors or active or moderate disease. The only time when they're recommended against is for patients who have no eye disease and no risk factors. Then they're recommended against. And for all other patients, it's pretty much, it could be a consideration unless the patient has contraindications to the steroids themselves, whether it's uncontrolled diabetes or some other underlying comorbidities. And when steroids were administered as part of the radioactive iodine treatment, endocrinologists were the most to prescribe them. And again, as Dr. Petros already alluded to, there is a shift in paradigm generally in terms of our treatment of hyperthyroidism, and accepting that long-term antithyroidal therapy is a good option for a lot of patients, especially for patients who have a moderate to severe eye disease that we don't want to subject to radioactive iodine. So again, the shift in paradigm is there, and we now accept that long-term antithyroidal therapy is safe and acceptable treatment for these patients. So what about thyroid eye disease here in Qatar? I consulted with our ophthalmologist, who Dr. Mehran Zino, who might be joining us today. In terms of his practice, he's interested in thyroid eye disease, and he's our go-to in terms of thyroid eye disease in our patients. And so thyroid eye disease here is mainly managed by endocrinology and ophthalmology, more so by ophthalmology, who will also involve our colleagues from rheumatology and radiation oncology when needed for, if patients require immunomodulator therapy or a radiation therapy. We don't have a formal MDT, so a multidisciplinary team in terms of management of these patients. So the management depends on the treating physician. There is a feel that steroids may be underutilized prior to RAI therapy, and that's why those survey results were a little surprising to me, just because it does seem that maybe we are not using as much steroids for patients who we opt to treat with radioactive iodine. And perhaps surgery is underutilized for patients who have more severe thyroid eye disease. As again, Dr. Petros alluded to, teprotumumab at this point is not currently available here in Qatar. It's not registered in the country, and so patients don't really have access to it. And that perhaps there might be a neglected psychosocial aspect also here in Qatar and the region, and probably beyond, for these patients who tend to have a poorer quality of life. So having said that, I thought I'd spend the rest of my talk on maybe kind of some open-ended questions on gaps in thyroid eye disease, both in our region and I feel more globally as well. So first of all, thyroid eye disease in euthyroid patients. So we've as endocrinologists, I think we've all had referrals from ophthalmologists or primary care physicians for patients presenting with thyroid eye disease, and their thyroid function is completely normal. And so the question is, how do we treat these patients, or do we treat these patients as endocrinologists? And so looking at some literature, so this is a case series of 7 patients with ophthalmopathy. So mostly female patients, mostly Caucasian, normal TFTs, and maybe some incidental thyroid nodules here and there. In terms of their autoimmune profile, mostly negative autoimmune markers. Some patients didn't have TRAb checked, and some had positive thyroid stimulating immunoglobulin. Some had a personal history of other autoimmune disorders or family history, such as Hashimoto's or rheumatoid arthritis. These patients were followed for up to 10 years. And in these 10 years, they've developed quite severe thyroid eye disease with CAS scores in some of 4 and 5 and 3, requiring treatment with steroids. And throughout these 10 years, they did not really develop any thyroid dysfunction. So does it make a difference if patient has positive autoimmune markers or not? Are we talking about a different syndrome? Are we talking about the same syndrome? Do we really change? So I think we can, we can discuss this at the end of the talk if we have some time. Which brings me to autoimmune markers in thyroid eye disease. So again, there's this notion of antibody negative euthyroid Graves ophthalmopathy. So these are patients who have normal thyroid function, who don't have antibodies, yet have features of thyroid eye disease. And so again, multiple articles are present, kind of discussing the different antibodies that may be at play, whether it's affecting the hyperthyroidism itself or affecting the thyroid eye disease. And so, I just wanted to point this out because it's also important to know what our labs measure. Probably in each of our institutions, we might be measuring different things, whether it's the immunoglobulins or the antibodies. And so it's important to know what your lab measures and to take that into consideration in terms of assessing your patients with thyroid eye disease and Graves' hyperthyroidism. So why might TRAb be negative in certain euthyroid patients with thyroid eye disease? Is it an assay sensitivity? Are we not detecting perhaps a low level of circulating TRAb? Are we detecting something else? So like a thyroid stimulating antibody or the immunoglobulins, which might be less related to the development of, or less implicated in the development of thyroid eye disease. Is it still an early disease course? So the circulating TRAbs are still, low and beyond the assay detecting level. Or, and having said that, we know that the normal TFTs and the normal autoimmune markers do not exclude thyroid eye disease, which, begs the next question. Is this semantics? Are we talking about an autoimmune cluster? Are we talking about an autoimmune cluster where hyperthyroidism and eye disease, not necessarily thyroid eye disease, may be part of that cluster, and other autoimmune markers such as anti-collagen antibodies that have been reported in the literature be implicated? So is this a bigger syndrome rather than just thyroid eye disease relating to hyperthyroidism or other thyroid dysfunction? And finally, I wanted to touch on the psychosocial impact of thyroid eye disease. So from the Danish studies, we know that mortality in patients who have Graves' orbitopathy is increased. There's a 23% mortality increase in these patients when compared to age and gender matched controls. And the cause of the increased mortality is not fully understood yet. So even with ruling out pre-existing conditions, the cause, that mortality differential was still there. Perhaps patients with Graves' orbitopathy present with more severe Graves' disease owing to that mortality. Is it the treatment of Graves' ophthalmopathy, the steroids, radiation? Does that contribute to the increased mortality? Or again, is this part of an autoimmune cluster that we don't fully understand or elucidate, is not fully elucidated yet? And does that play a role on the increased mortality? But what is more surprising is, again, from the Danish study, is that death by suicide is also increased in patients with Graves' orbitopathy. So if we look here, patients who had Graves' disease and Graves' orbitopathy and patients who had Graves' orbitopathy alone with euthyroid disease had an increased risk of or increased rate of death by suicide compared to patients who only had Graves' disease. So is this preventable? Do we think that this is preventable? Should our mental health specialists be included early on in the management, in the multidisciplinary management of our thyroid eye disease? So I'd like to kind of leave these questions out in the open, and would love to hear from Dr. Petros and from our audience as well in terms of their experience. Thank you.
Thank you, Dr. Tanya, for nice presentation, sticking to the time. Now we have plenty time for questions. We have 10 questions on the Q&A, and I will start by me. If you, Dr. Petros, please, if you don't mind, how frequent you give IV steroid without doing CT? Are you feel happy? The guideline recommend the CT indicated only in certain situations.
Yeah, so most of our patients will have treatment without imaging.
Okay.
So there are certain indications where imaging is really
yes, well known in the guideline, sure.
So if you're uncertain about the diagnosis, and what Tanya referred to, the patient with euthyroid Graves' orbitopathy, for instance, it's relatively rare. That is an indication for imaging, as is if the disease is completely unilateral, because there are conditions that can emulate it. So diagnostically, it is important.
Yes.
I think if you're thinking about surgical treatment at some point in the future,
Yes, sure.
CT scan is.
Can we see the slide of upper eyelid retractions in your slide, or no, you don't have access? Can you show the slide? Yes. Okay. Is it easy to diagnose upper eyelid retractions? Because you said 1 millimeter retractions mean mild, more than 1, it will push us to the mild to moderate and severe, the upper eyelid retractions.
So eyelid retraction is important, and there are.
Is it pathognomonic, the lateral, what we call the lateral flare? Sometimes we call it lateral flare. Is it pathognomonic for thyroid eye disease? Or frequent you put much weight on the without exophthalmos?
Okay, so there's more than one questions there, Dr. Mansour. So first of all, the upper lid retraction is an important sign, because it's the commonest sign for thyroid eye disease, but there are some pitfalls here. So don't put any value on upper lid retraction whilst your patient is thyrotoxic, because as we know, any kind of thyrotoxicosis will cause upper lid retraction. And you have to make sure your patient is euthyroid before you evaluate it. When you evaluate upper lid retraction, you need to make sure that your patient is completely relaxed, because anxiety is another cause of upper lid retraction. You place them in the primary position, you make them relaxed, and then you can assess it. Lateral flare, I did have an example in my slides. I can't find my slides right now. They've disappeared. Okay. It's when, as you said, the lateral part of the lid tends to go sideways. It's fairly characteristic of thyroid eye disease.
Thank you.
You almost never see that without exophthalmos.
Yes, both should be present. The other question from Dr. Ali Hamza is there is any correlation between TRABs and thyroid eye disease? And if that's the question, how you explain we have rare, Dr. Tanya mentioned that we have rare cases of TRAB negative thyroid eye disease. Yeah. So that, is it routinely you have to check for TRAB, for Professor Petros and Dr. Tanya, both of you can answer the question because both of you talk about the antibody and the disease.
Yeah. Tanya, why don't you go first?
So I do like, thank you. I do like to check the TSH receptor antibody, both for the hyperthyroidism and for other, manifestations of the thyroid eye disease, because we know that is the main antibody implicated in the progression of thyroid eye disease, and it gives us an indication on, how long we're treating the hyperthyroidism for our response in terms of antithyroidal drugs, as well as even when a patient doesn't have clinically apparent eye disease, a high TRAb does predispose to developing thyroid eye disease, especially if we are going to treat with radioactive iodine. So that is part of my routine, workup for patients with hyperthyroidism.
If I may add to that,
Yes.
So TRAbs are closely associated with both severity of thyroid eye disease and activity. That is on a population level. So like many things, if you take it down to the individual, then you start to see exceptions to the rule. But the majority of people with thyroid eye disease, before they get treated, because the minute you start treating with antithyroid drugs or with steroids, then your TRAbs start to be influenced. They can go down. So before treatment, there are some studies doing exactly that. They tend to be fairly useful even in euthyroid eye disease. And especially if you use the bioassays, which tend to be a little more sensitive than the binding assays, they're good markers. So there's some evidence that if you have thyroid eye disease and after about 6 months, you continue to have high TRAbs, that usually indicates that your disease is going to progress.
There is a question, it seems to be pragmatic. Why not to use steroid for every thyroid patient, even without thyroid eye disease? Because it's autoimmune disease. It seems to be odd question, I think. Professor Petros or Dr. Tanya, why not to use a steroid routinely in thyroid, even without thyroid eye disease?
I mean, I think as endocrinologists, we only use steroids when absolutely needed. So we all agree that the slew of side effects associated with steroid therapy doesn't make it harmless. So we all reserve no matter what it comes to, only if there's any evidence that steroids are going to help with whatever condition we are treating, then we'd rather not use steroids.
Dr. Ihab asking about the preventive measures. You asked Professor Petros, you mentioned some preventive measures like quit smoking. You have any other preventive measures?
Well, there is, as I said, evidence that if you use selenium in patients with mild disease, it prevents their progression. All the evidence about prevention is by association. There aren't any good prospective sort of interventional studies. So we think smoking, dysthyroidism, radioactive iodine are risk factors because they tend to be associated with progression.
Do you personally believe in selenium?
This is a very good question, Dr. Mansour, and I will refer back to the MR test. You need to have 2 randomized controlled trials, and there's only one. It is used very extensively on the basis that, what harm can it do? Well, there is no intervention that is free of harm, so we need to remember that.
Yes, in your practice, who will give IV solomidrol, methylprednisolone, the endocrinologist or the ophthalmologist?
In our center, it's the endocrinologists that are in charge of that, and I think that makes sense because we're used to dealing with the side effects of steroids or monitoring their treatment. It doesn't matter. I think it needs to be administered in a safe environment. That's the key, and it doesn't really matter who it is.
Dr. Omar Abu Hajla from Jordan, he said it is an autoimmune disease, thyroid eye disease with euthyroid and negative antibodies. Who should treat this patient? Ophthalmologist, immunologist, or endocrinologist? He said euthyroid, normal ultrasound, nothing, but only they have only thyroid eye disease. Who
I think it
should,
depends on the severity of eye disease, I would say. I mean, if it's mild, then I think, as endocrinologists, we can deal with that. And the important thing is to just, monitor. We know that in a subset of patients, thyroid eye disease precedes the hyperthyroidism, the onset of hyperthyroidism. So we just also monitoring of the TFTs in those patients is important, just to kind of keep an eye on when and if hyperthyroidism occurs. But probably in more severe cases, we would involve our ophthalmologists.
Dr. Wa'am Hussein, he said, are you happy with the selenium may cause is a diabetogenic drugs? Are you aware or afraid from diabetes induced by selenium?
Yeah, so you're quite right. There is some evidence for that, and there is also some not so good, but some evidence that it may increase the risk of cancer. I think that these risks are really small quantitatively, and the associations are really attenuated. Like everything else in medicine, you've got to make a judgment on the individual basis of each patient. If you think that that patient is going to benefit, then the balance is in favor. There's nothing.
For both, yes.
Nothing
For the
simple.
both panelists, do you have any evidence for the benefit of vitamin A and melatonin used in thyroid eye disease?
I'm not aware of any evidence.
Okay. Okay. The other questions from Dr. Khalid. He said, thank you for the presentation. How you confirm a TRAB negative thyroid eye disease? I think this is to Dr. Tanya. You tackled this point. How you diagnose just on upper eyelid retractions and, staring eyes, common anxiety, etc. How you diagnose thyroid eye disease with a TRAB negative?
So I think I'll reflect back to Dr. Petros, because I think he already answered that. I mean, definitely clinically, and these are cases where typically a CT or an MRI of the orbit is done to confirm the extraocular muscle involvement, the and basically the thyroid eye disease. And I'm not sure if there is a role for excluding any other, but the CT and the MRI typically would confirm that.
Yeah, I agree with that, and it really is important, because there are some causes in the differential diagnosis that are really nasty. So you can have lymphoma, for instance, of the orbit, and other conditions. So it is important. So, and just one little point: when we are concerned about the differential diagnosis and do a CT, we usually also administer contrast, because that can help in differentiating between benign and malignant disease.
And you do biopsy the eye lesion if it is unilateral? There's another question. Do you do biopsy? I don't from where to take the biopsy.
Yeah, so biopsy is an important part of it in cases where the diagnosis is unclear and you're suspecting an alternative diagnosis. Now, the biopsy will never tell you whether you got thyroid eye disease, because the features histologically are not diagnostic. The biopsy will tell you whether you got a malignant process or not.
Yes.
So we do occasionally do that to make certain we're dealing with something benign.
A question to Professor Petros. Are you aware of commonly see patients with a TRAB positive or TBO positive thyroid eye disease? How to monitor those people with hypothyroidism in your practice? Thyroid eye disease.
Yeah, sure. I mean, it happens in up to about 5% of all cases of thyroid eye disease. It's in association with
TBO positive.
TBO positive, yeah. They tend to be more frequently unilateral. I think Tanya touched upon that. So the management is the same as anybody else with thyroid eye disease. You pay obviously attention to ensuring that they remain euthyroid, but otherwise the management of the eyes is the same as anybody else.
Can I ask a question?
To
Dr.
both panelists, do you prefer, are you wearing any of the steroid regimen? Do you have any preferable steroid regimen other than what's written is 500 milligram weekly for 6 weeks, then 250 for 6 weeks? Do you have other regimen for IV steroid?
Is this question for me?
Both of you.
Okay. Tanya, do you want to go first?
I mean, typically, I follow the guidelines, and typically at the time in our practice, ophthalmologists tend to actually give the IV methylprednisolone. So we typically defer to them in terms of the regimen, but it's usually a high dose, long taper regimen.
So there's been there is at least one randomized controlled trial that looked at different doses, cumulative doses of pulse therapy, and the one that you mentioned, the 500 milligrams for 6 weeks followed by 250, is the optimal one. You can get a little more response in terms of double vision or diplopia if you use the higher dose, but again, you begin to get into trouble with side effects of steroids if you go beyond that regimen.
Dr. Petros, the question is that what do you believe in long-term antithyroid? That's to say, Faridun Azizi school, where they prefer 60 months at least of antithyroid, and how you define long-term antithyroid treatment?
Yeah. Well, I mean, in my book, anything beyond 2 years, which is, up to the standard, is long-term. I think these are always individual decisions with your patient. You have to take into account what is our current knowledge about safety and efficacy, but it's also equally important to what your patient's preference is, what the values are, what the concerns are. And I think for many patients, this is a very reasonable solution. And I really don't think it is right, if I may say so, for us to put pressure on patients after 2 years of antithyroid drug treatment to come off it. They need to be aware that they've got choices. And I think as long as they tolerate the treatment well, and as long as they maintain euthyroidism, there is no compelling reason to push them in the direction of radioactive iodine or some other treatment. But in the end, there's always in medicine, there's the science and there is the art. I think the art of medicine is how you translate that with the individual patient in front of you.
Dr. Umayma asking about if there is any role for oral steroid. Short answer, please. We have only 3 minutes. Any place for oral steroid?
I think the studies have shown that at least in mild and moderate disease, that oral is no different than IV, but perhaps in more severe cases, IV is recommended.
Yes.
I think so. I broadly agree with Tanya. The evidence overall tends to suggest that pulse treatment is more efficacious. But please, this is Eurocentric medicine. We tend to apply what we do in Europe to the rest of the world, and the rest of the world does not have access to intravenous steroids. Let's not forget.
Have you ever seen liver injury due to IV methylprednisolone?
We have seen it. Yes, it happens.
You have seen it.
Occasionally, not very often, but it does. Yeah.
Yes. And the other question, I think that we have only 2 questions. We have short of time. And how you follow patient after decompression surgery for thyroid eye disease? What to do for the patient? Can you allow to use the steroid again, IV sodium methylprednisolone, or just follow the patient after decompression surgery?
So we do decompressions for 2 main indications. One, the most common one, is for patients with proptosis, and they usually are in the burnt out phase, where we wait for them to settle down before we recommend decompression. The other indication is optic nerve compression, and at that point, most patients have active disease and they may need more steroids afterwards. So they do need follow-up either way to ensure that the vision is improved and maintained. Patients who have a decompression because of proptosis usually will require some additional treatment with surgery to the lids or the eye muscles. So it is a long way.
I think we need a short answer. Dr. Nazar, he said, if 12 cycle of IV sodium withdrawal failed, what to do in a developing country? May I suggest MMF because it's available for renal transplant people? You advise mycophenolate nowadays? Or you have to use mycophenolate with the same time with the IV sodium withdrawal?
Well, I showed you the evidence. I don't think the evidence suggests that it is efficacious. I think that's a difficult problem. What do you do? I don't have an answer, I'm afraid.
Dr. Tanya, you show us about MMF in China, something.
Dr.
Mycophenolate.
Petrus showed, yeah, and I think that that study was retracted, yeah. So
Yes, retracted.
Yeah.
Yeah,
So there-
any role for carbimazole or methimazole to improve thyroid eye disease, Dr. Mohammed Salah?
in patients who are hyperthyroid, yes, but
Yes.
in thyroid
For the
patients.
thyroid eye disease, I mean,
Yeah.
a treatment. Dr. Petros, he said the treatment of hyperthyroidism to the euthyroid level, but not overtreat, may improve the thyroid eye disease. I think that's what I get from your.
Yes. And I don't know, Dr. Petrus, do you do a block and replace approach in patients with, you know, moderate to severe disease to prevent the variability in thyroid function? Do you
Well,
prefer that approach?
That's been my preference for every patient with Graves' disease.
Okay.
Yes.
I think now we are finishing, come to the end. Thank you, Professor Petros Piros, for the nice presentation. Dr. Tanya Jaber for this webinar. I think we will see later on the thyroid update series in the future, but this is today only on the thyroid eye disease. We hope we will meet you again in the future for another webinar. Thank you very much.
Thank you.
Great thanks
you
for the
too.
nice presentation and for the audience. Thank you very much.